So this is a structured Viva task assessing communication with colleagues, communication with patient, information gathering, applied clinical knowledge, and patient safety. You are the ST5 attending Gynae Theatre today to assist your consultants list. The first case on the list is Madeleine Royal, is a 46-year-old who is booked for abdominal hysterectomy. She has a 16-week sized uterine fibroid. She had previous 2 cesarean sections and her BMI is 37. The examiner will discuss with you regarding her preoperative preparations, steps of the procedure, including appropriate approach and her postoperative care plan. So it can come as a separate station or can come as a part of gynae list. So we need to know and fulfill whatever question can be asked about hysterectomy. So the first question may be what are the preoperative checks, or what are you going to do for the patient as a preoperative. So any patient in the list, we need to take the history. So first of all, I'll go and take the history from the patient and confirm about what is her main complaint, just to confirm that the indication of the surgery is still present. And then I'll go ahead with the analysis of her complaint, whether she is having bleeding, pain, pressure symptoms. So whatever symptoms she's having, I need to ask how these symptoms affecting her life and whether she is really wants to go ahead with the surgery or no, and if anyone has explained to her the alternative treatment for that or no. Because sometimes if the patient wants to retain her uterus, we can offer her trying to do myomectomy, trying to do uterine artery embolization, or if she's really want to remove her womb, we can go ahead. Then we need to go through her history. We need to know about her last menstrual period. She is 46, so she's still in the childbearing period. We need to know when was her last menstrual period and whether she's sexually active and what kind of contraception she is on, because it's contraindicated to do any surgery within 4 weeks from hormonal treatment. So if the patient is receiving HRT or hormonal contraception, she should stop them 4 weeks at least before her surgery. Be careful if you find your patient is still using the hormonal contraception or HRT till the day of the surgery. That means she's not safe to go ahead. We need to cancel and postpone her surgery for further date. Okay? Then we need to ask further about whether she has been diagnosed before with any pelvic inflammatory disease or sexually transmitted infection, because that will give us an idea about how much adhesion in her pelvis we can expect. And also we need to ask about her smear history. It's very, very important because it will differ when the patient has not really normal smears before, because sometimes if we are going to remove the uterus for the fibroid reason, the fibroid may be present at very critical position, between the cervix and bladder, or maybe cervical fibroid, and then when we try to remove it, it will be very difficult. So sometimes we may need to do subtotal hysterectomy instead of total, and that's only can be done if the patient's smear history is normal. And if that happens, we need to confirm that the patient has to go as routine for her smears. However, if she is having any abnormal smears, it's unlogic to leave this cervix under any circumstance. So in that case, we need to involve other surgeons to have proper dissection and to have proper removal of the womb. Then we go for the obstetric history for her. We need to know about how many pregnancies have you ever been pregnant before, and what was the mode of their delivery. So this patient is having previous 2 C-sections. That means we can expect adhesions inside, and for that we need to review her previous operative notes to see whether any complication happened during her C-sections or no. We need to confirm for her also that she has completed her family, she doesn't want any further children, and because we are going for hysterectomy. Okay. Then we need to ask about her medical history, whether she's having any other medical problem. If she's diabetic on insulin, for example, we need to shift her on sliding scale because she is going for a surgery. If she's like taking regular steroids, we need to increase the dose of her steroids, um, because the operation itself is considered as a stressful situation, and our normal bodies, when we go into an operation or delivery or a stressful condition, our cortisone level will go high by default. But if the patient is dependent on external steroid intake, and and she's taking in a regular dose, it's no, there is no fluctuation on the dose according to the stressful conditions. So we need to be aware that if she's steroid dependent, we need to increase her dose during her surgery. And we need to ask about any other medical problems, like if she has, for example, myocardial infarction or cerebrovascular accident recently, we need to postpone her surgery for at least 1 year, from 6 months to 1 year. Okay, and also we need to ask about any other surgeries apart from her C-sections, because that also give us idea about any adhesion and how the difficulty we expecting her surgery will be. Don't forget to ask about her allergies, because we are going to give a preoperative antibiotic prophylaxis. So we need to know really whether she's allergic to anything or no. And also regarding her BMI, it's mentioned here, but if it is not mentioned in your stations, it's very important to ask about the patient BMI, because it will also depend, like, you know, it will give you idea about the possible precautions you need to take, especially in the moving and handling the patient, especially in the incision and the dressing you are going to put, the closure, suture material, and you know, different things. And also if you would consider extra VTE risk assessment or prophylaxis or antibiotics or anything related to high BMI. It's very important to ask this patient about any objections regarding blood transfusion, because, you know, hysterectomy is considered to be a bloody operation. So we need to know really if we face, like, you know, bleeding to the extent that she needs to receive blood transfusion. Is she happy to go ahead for that or no? We need to ask about her special habits, including smoking, alcohol, and any recreational drugs. Smoking, if it is there, will increase her risk for VTE. And alcohol, actually, if the patient is alcohol dependent, um, that may affect her liver functions. And also because vitamin K is a very important clotting factor which is produced by the liver. So in case of the patient who's using alcohol for a long time, we need to give her vitamin K supplementation just to avoid any risk of bleeding. And also, by the end of taking her history, we need to assess her VTE risk and decide what we are going to give. So some patients will need elastic stocking, and also we need intermittent pneumatic compression. We need to let her, like, know about good hydration and early mobilization, and some of them will need blood thinning agents. Um, so that depends on their VTE risk assessment. Some of the patients are already on blood thinning agents, and that's why we need to do bridging thromboprophylaxis. So it's very, very important to know what is the patient taking for coagulation. Like sometimes the patient will come to you and she's on warfarin and she has already bridged 1 week ago, and she is on therapeutic low molecular weight heparin. So if she's taking therapeutic low molecular weight heparin, the last dose before her surgery should be at least 24 hours back. Okay, if she is having a recent low molecular weight heparin, we need to postpone her surgery until she completes 24 hours. Okay, and after that we need to bridge her again. So that's if she's on therapeutic Clexane, we need, or low molecular weight heparin, we need to do the surgery only after 24 hours. Okay, don't forget to involve the hematologist in your case if she is on any blood thinning agent. It's very, very important. That will help us on knowing how to bridge her back post-operatively and pre-operatively, when to stop, when to start, and what kind of medication, and so on. Okay, we have already another station speaking in detail about bridging thromboprophylaxis. It's in when you go to the playlist, you find it in the teaching module. So after you do have VTE risk assessment, you take her history. Do we need to examine this patient? Yes, we need. We need to see whether she has, like, what is the size of her uterus. We expect a large size because 16 weeks fibroid size means that it's maybe just below the umbilicus, and that will give us an idea that how big is the uterus and the fibroid. So we need to examine, we need to see whether it is fixed or mobile. So it's better to examine the patient under anesthesia. So anyway, she's going to be anesthetized, and then we need to examine her when her muscles are relaxed, so that we can do also bimanual examination, feel the adnexia, do proper assessment about mobility and size and everything. So we can speak to the patient and let her know that we need to examine you while you are asleep, or if she's going to have regional anesthesia, we can tell her we are going to examine you under anesthesia and decide what type of incision we are going to do. So the types of incision can be either midline incision or low transverse incision, and we will speak about them soon. One of the preoperative thing or preoperative care is to do or to ensure that we are fulfilling the enhanced recovery program. So the patient has to be educated before surgery about her, like, being active before surgery, doing regular exercise, eating healthy, and the day she should only be admitted on the day of the surgery unless she needs proper regulation of blood sugar or blood pressure. She can come the night before, but otherwise she should come only on the day of the surgery, and she should not be completely fasted. she should continue drinking fluids and sips of water and sometimes carbohydrate drinks till 2 hours before her surgery. We don't need to do bowel preparation anymore, and we will encourage her to be mobilized early. We will intraoperatively, we will avoid using drain as much as we can, but if we need to use them, we need to remove them as soon as possible once is not draining anymore. And also we need to give her early post-operative oral nutrition, and also early removal of Foley's catheter. We need to tell her that we are going to take care of her pain. However, we need to avoid too much opioid sedation because you know that will prolong her recovery time. All these items will be included in what we call enhanced recovery program, and the aim of that is to ensure early recovery and avoid the post-operative complication. Okay, so we have taken the history, we fulfilled the enhanced recovery program, we examined the patient, we have VTE risk assessment. What we need to do now, we need to take the consent. So usually the consent form is taken at the same day of the surgery, and we need to explain everything to the patient in terms of the benefits and risks of her surgery. So we are, what are the approach we are going for? In a case like that, we don't really need to struggle. So we are not going to try with laparoscopy because first, she's high BMI lady. Second, she has a very big fibroid, and we may struggle to go through the umbilical route. If we are really need to go, we need to go through the palmar point, and consider you are successful to remove the uterus, and then how you can retrieve the specimen out through the laparoscopy. Sometimes you may try to do laparoscopic assisted vaginal hysterectomy. However, with this large fibroid, there is no guarantee that you can retrieve the uterus through the vaginal route. So the best choice is to go through abdominal hysterectomy. So going through abdominal hysterectomy will give us another question: what type of incision you are going to do? So we have two types of incision, as we mentioned earlier. Either we will go vertical midline incision or low transverse. So the low transverse, all of you knows, you know about it. It's either Finch-Thiel or Joel-Cohen, and that's the same incision we are going for when we are doing a C-section. The advantage of low transverse incision is that it is low risk for scar dehiscence, less post-operative pain, early recovery. It's better cosmetic than the other one, and it has good healing chance. However, it will not give us, like, easy access. It will not help us if the mass is very big, no exposure of the like if it is fixed or adhesion, or we need to to have a good exposure, it will not help us. However, if we give her a vertical midline incision, it's a rapid incision, simple closure, and it will give us easy access, and it will help us for the large masses manipulation, and also if the mass is fixed to the surroundings, so we can manipulate easy, and it will give us better exposure. However, it's high risk for dehiscent scar. It's causing more pain, and that's why the recovery will take longer time, and also it's not cosmetic in appearance in comparison to the Joel-Cohen or Finch-Thiel. And also the healing may not be perfect because sometimes It may be like, liable for herniation or anything. Okay, so that's regarding to the incision. We need to also discuss regarding keeping or removing the ovaries. So if the patient is not having any family risk of ovarian cancers or breast cancer, or herself any previous history of breast cancer, for example, or any possibilities she may carry the gene or anything like that. So we will leave the choice for her and explaining that if we keep the ovaries later on, if any pathology happens, that will be very difficult to operate because of the risk of adhesions. And if we remove them now, we may deprive her from the benefit of hormone that's released by the ovaries, and she has to take HRT to protect her bone, heart, and to have a normal sexual life. So that's if she doesn't have any risk. If she has a family history of ovarian cancer, breast cancer, or anything like related, we need to counsel her for removal of the ovaries, and that's for her best interest. But if we are going to remove the ovaries, we need to explain to her that if she is not willing to take HRT, that will put her straight away on menopause, and she may suffer from menopausal symptoms, including night sweating, hot flushes, and also uh, all the, like anxiety, depression, mood swings, and all the menopausal symptoms, unless she is taking HRT till the usual age of menopause. We need also to speak to her regarding the possible difficult surgery today, because she has 2 C-sections and high BMI, and it may take longer time than what we expect, and the risk of complications may be higher in her condition. So the benefit from that surgery today is to take her womb out and relieve her symptoms, whatever the symptoms are. And the possible risk from her surgery, we need to start with the common risk, which is pain, bleeding, infection, and then risk of injury to any organs around, which may be the bladder, the bowel, the ureter, and also uh, risk of increasing scarring inside her tummy, like adhesions because of repeated surgery, and that makes her further surgeries, if necessary, will be difficult and taking more longer time. And also one of the risks is she may need to return to theater. We need to tell her that the risk of infection can be either wound infection because of her BMI, or pelvic abscess or pelvic collection. And also the return to theater is a possibility if we suspect anything like bleeding inside, or anything like voltehematoma, for example, or anything like that. Um, there are the risk of VTE. We need to tell her the risk of developing clots in your legs and can migrate to your lungs. So we need to tell about all the possible risks. Don't forget to take the sign for blood transfusion if necessary, and if she has any advanced directive regarding objection or anything related to blood transfusion, we need to inform in her consent, fulfill it in her consent. Okay, so that's all of her preoperative care. Going ahead to the steps of the surgery, that's one of the questions if the examiner want to ask, because this station actually can't come like a full topic like that. It will be a part of a list, and we need to answer some question, or it can be separate, but it will not be very huge like that. So don't be scared. I'm just collecting all the information needed about the station. So the steps may be like, when we go through the incision, whatever it is, first of all, we need to put clamp on the either sides of the uterine conure, just to elevate it in a vertical position to be easy to manipulate. And then we need first to ligate the round ligaments. So I'll put 2 clamps on the round ligaments and cut in between and ligate with transfixation. And the round ligament will give me access to open the broad ligament, okay? And I will start to dissect through the broad ligament, posterior and anterior. And then the next step will be decided according to we are going to keep the ovaries or remove the ovaries. If we are going to remove the ovaries, we need to ligate the IP ligaments, which are the infundibulopelvic ligaments, okay? So we will put 2 clamps on the infundibulopelvic ligaments, and please take care because infundibulopelvic ligaments is present in the pelvic brim, and that's the place which we may injure the ureter here. So ligate and try to visualize the ureter before you do this step. Ligate and cut in between, transfix, do the transfixation suture on your pedicle, and then go and do the same on either sides. Then try to dissect through the anterior leaflet of the broad ligament and go down and clamp and ligate the uterine artery after displacement of the bladder. So first displace the bladder down, and that's very important step before before ligation of the uterine, because the ureter is crossing below the uterine artery to go inside the bladder, right? We remember the famous sentence of water under the bridge. So we need to just displace the bladder down, further down, and it will take the ureters down with it, okay, down. So I will just clear the field from the ureter and to be easily ligating and safely the uterine arteries. So I'll put the uterine artery clamp on either sides, ligate and do transfixation, and then after dissection I'll start to dissect furthermore, and then I will ligate the 2 uterosacral ligaments, and I will try to dissect down furthermore till I reach the cervix, till I feel that I am just handling the cervix. In that situation I'll put my transverse clamp and take the uterus out, cut and take it out, and then I will suture the vaginal cuff in 2 layers, one interlocking continuous layer, and I will close the retroperitoneum back. Okay. What we need to do before closure? It's a very, very common question. So don't close unless you go through all the pedicles and look at them, and then do your counts, like swab, needles and instruments. Check your urine that it is clear, and then safely you can close the abdomen. What about her post-operative care? As we told earlier, we need to keep her active as soon as possible. Remove the Foley's catheter whenever she's mobile, and try to give her as early as possible post-operative oral feeding, and also encourage early mobilization, and according to her VTE risk we need to give her whatever needed in terms of either blood thinning agent, low molecular weight heparin, or if she's low risk, we can just give her the elastic stocking during inpatient time, and so on. Okay, thank you.